Mary is a 26-year-old female patient who visited our practice complaining of severe neck pain and reduced range of motion. She was involved in a motor vehicle accident 16 months prior to consulting us, shortly after her little brother's funeral. He had died in a car accident. She said her neck pain was not so bad initially after the accident, but has become progressively worse. She recalled being very emotional after the accident, though she wasn't sure if it was because of the accident itself or the death of her brother. Since the accident, her life has changed in many ways. She no longer moves her neck. She has stopped driving and has moved back in with her parents to make it easier for them to drive her around. She used to love her job as a receptionist. However, she is now considering reducing her work hours as she feels overwhelmed by the social interactions and has become sensitive to sounds and lights. And she has withdrawn from seeing her friends as she finds it hard to maintain communication. Mary probably sustained facet joint and soft tissue injuries from the reciprocal force from the motor vehicle accident. This is classified as a whiplash injury. In the acute phase after a MVA, local neck pain is associated with headaches, reduced neck mobility, and other non-specific symptoms. This is normal as the brain wants to protect the area for healing. In the majority of patients post-MVA, their symptoms gradually disappear within 2 to 3 months. When symptoms persist beyond that period, it is likely that the pain is no longer maintained by peripheral damage. Like Mary, this is seen within the first year post-trauma and is known as whiplash-associated disorder. Whiplash-associated disorder is characterized by loss of physical and psychosocial function, maladaptive pain behavior, and participation restrictions such as reduced working capacity. Altered cognitive behavior, like fear avoidance, may exacerbate the effects of post-traumatic stress on pain. Psychological distress is a common symptom and has been found to be more relevant than collision severity in predicting duration and severity of neck pain. The symptoms may be triggered by whiplash injury or may be a manifestation of post-traumatic stress or depression. Psychological distress from the MVA in Mary's case was exacerbated by the death of her brother. Prior to Mary's accident, the death of her brother may have served as a psychological stressor which activated the HPA axis. This was exacerbated by further activation of the axis from the trauma of the MVA and made her vulnerable to developing chronic pain after her accident. Normally, under acute stress, the hypothalamus releases corticotropin-releasing hormone. This stimulates the anterior pituitary gland to release adrenocorticotropin hormone. The ACTH acts on the adrenal gland and causes cortisol to be released. Usually once the stressful situation has been removed, a negative feedback loop stops the secretion of hormones. Due to Mary's grief from her brother's death, the trauma of the MVA, and her current psychosocial contributors, Mary is stuck in a stress cycle, which is playing a greater role in maintaining her pain than the initial tissue damage. Initially, the tissue injury from the MVA would have activated A delta and C fibers in response to noxious stimuli. The nociceptive input would have been transferred to the second-order neuron in the spinal cord. Cytokines and inflammatory mediators released from damaged tissues, as well as the primary afferent neurons, would have caused a buildup of pro-inflammatory mediators in the periphery. This would have resulted in peripheral sensitization, the mechanisms of which are characterized by lowered firing threshold of primary afferent neurons, an increased firing rate, and activation of silent nociceptors. Thus, shortly after the initial injury, we can assume that Mary would have presented with primary hyperalgesia and inflammation, which are clinical signs and symptoms of whiplash injury. This is normal in the initial stages. However, 16 months later, we would expect tissue damage to have healed. Mary still experiences pain, which is an indication of centrally mediated pain and not an indication of tissue damage. Central sensitization is defined as an amplification of neural signaling within the central nervous system that elicits pain hypersensitivity. CS is predominantly shown in Mary's case and is a cardinal feature of whiplash-associated disorder. Cortical upregulation describes increased excitatory nociceptive transmission in the brain, which is where the conscious perception of nociception is interpreted as pain. Mary presents with the following signs: fear avoidance, depression, kinesiophobia, social isolation, hypersensitivity to light and sounds, and features of PTSD. Mary's persistent fear of driving may result in overactivity in the amygdala, resulting in cortical upregulation and increased pain. Her kinesiophobia and resultant lack of movement results in decreased firing in the premotor cortex. This reinforces the lack of neck movement and contributes to her stiffness. Her reluctance to move is also an indication of aversion to pain, which shows activation of the ACC and insula. These sites are also activated in social rejection and loss, which are prominent in Mary's presentation. Mary presents with apathy and anhedonia, which are signs of depression. Depression has widespread effects in the brain. The neurotransmitter cholecystokinin is often elevated in people with depression and may act as a mechanism contributing to descending facilitation. The psychological effect of having an MVA is linked to developing PTSD and depression. Mary's depression is also linked to her social isolation and the loss of her brother. Mary's hypersensitivity to light and sound may indicate symptoms of PTSD. PTSD has been shown to be associated with increased activation in the amygdala, anterior insula, and decreased activation in the prefrontal cortex, extending to the ACC and hippocampus. PTSD may thus be contributing to the continual dysregulation of the HPA axis. Given the overall hyperresponsiveness of central nervous system neurons, central sensitization may explain Mary's hypersensitivity to bright light and sound due to abnormal sensory processing. This is normal in patients with whiplash-associated disorder and may appear quite rapidly after the initial whiplash trauma. These symptoms have an important predictive ability for the development of chronicity. It is evident that there is a complex interaction of activity in many different areas of Mary's brain. To summarize, the ACC, prefrontal cortex, insula, and amygdala, which form part of the limbic system, integrate and interpret cognition and motivation. The S1 and S2 are involved in the quality and location of her pain, making up the sensory discriminative aspect. The output from this integration and interpretation is pain, stress regulation, and action programs. Sites like the anterior cingulate cortex, insula, and the amygdala have direct communication with the PAG and RVM, allowing them to modulate pain through descending facilitation. This seems to be a predominant mechanism in Mary's case. Due to the activation from cortical sites, there's increased stimulation of the on cells in the RVM by excitatory neurotransmitters. This can contribute to spinal cord sensitization. We can therefore assume that Mary has clinical signs of secondary hyperalgesia and allodynia. The mechanisms that underlie spinal cord sensitization are reduced firing threshold, increased receptor field size, and increased responsiveness to stimuli. Under normal circumstances, descending inhibition maintains a balance between excitation and inhibition at the spinal cord. Mary's maladaptive HPA axis contributes to continual corticosteroid release. The neurons which synthesize inhibitory neurotransmitters, such as serotonin, are reduced in the presence of corticoids. Therefore, there is a loss of descending inhibition via these neurotransmitters to the spinal cord. The locus ceruleus is another important structure. It maintains activity in the HPA axis through its excitatory connections with the hypothalamus through the release of noradrenaline. Its activity is also upregulated by the products of the HPA axis, such as CRF. During stress and social isolation, the LC causes increased synthesis of noradrenaline. This stimulates increased release of corticotropin-releasing factor, which maintains the HPA axis. As the cycle continues, cortisol levels increase, and cortisol changes from being anti-inflammatory to pro-inflammatory. Whiplash-associated disorder thus represents a dysregulation in multiple systems that interact with each other to maintain a state of persistent pain. Mary's personal emotional state of grief prior to the MVA likely played an important role in amplifying her reaction to the stress and threat of the accident itself. Compounded by the whiplash injury to her neck, this may have perpetuated a dysregulated maladaptive stress response. The prolonged stress response may have interfered with normal tissue healing and repair, and contributed to prolonged pain, kinesiophobia, and fear avoidance. As these consequences persisted, they started to affect Mary socially, as she stopped driving, withdrew socially, and developed a heightened sensitivity to light and sound, which may act as threat cues. This has left her feeling overwhelmed and wanting to withdraw further by reducing her work hours. These changes further contribute to her decreased mood and post-traumatic stress, which continue to reinforce threat and activate stress in a perpetuating cycle that maintains persistent pain. The column to the right shows an adaptive stress response that favors healing and return to engagement with life. It provides hope that with effective treatment strategies targeting perpetuating factors, she may develop the resilience and adaptability necessary to recover. In summary, it is clear that cortical upregulation is the predominant driver maintaining Mary's pain. This case firmly reinforces the fact that pain is not an accurate representation of tissue damage. As clinicians, we need to be adequately skilled in recognizing clinical signs and symptoms that point to various peripheral, spinal cord, and brain mechanisms that may be contributing to a patient's pain. This enables us to provide appropriately targeted treatment and ensures optimal recovery.